target should be around 60 to 70 millimeters mercury. Of course, we need to manage seizures, okay, because that would increase the MRO2. And vasospasm. Calcium channel antagonists such as nimodipine are actually being started, and that is maintained for 21 days. It is safer to use tablets rather than IV because that can lead to significant hypotension or even arrest. Okay. So for hydrocephalus, it can be dealt with by giving your surgically or even what you call this, doing a ventricular drain. How about steroids? There is no room for steroids in cerebral edema brought about by subarachnoid hemorrhage rupture. Okay. So in terms of intervention, there's an endovascular approach and also there's clipping. Okay. So what is actually more beneficial for the patient? So there is a study that I'll be showing you later on this one. So this is a picture of a clipped aneurysm, okay? And this is the endovascular technique. In the endovascular technique, it is very important that there is a neck. So it's actually easier for the, what you call this, the endovascular neurosurgeon to address this aneurysm if the aneurysm has a neck, because he sends coils to that aneurysm, and it has to be contained in that aneurysm. Otherwise, if it spills out, it can actually cause a stroke. So there's this study called the ISAT trial comparing clipping versus an endovascular approach, and what they actually say is that, what they call this, so this is the only prospective randomized trial of surgery versus endovascular treatment of ruptured aneurysm. It was terminated early when 24% of patients treated with endovascular therapy died during that time. Okay, after 5 years, the risk of death was lower in the coiling group. Okay, so that's something we need to remember. So the risk of rebleeding is low, but more common in the coiling group. So more pictures. Okay, just to summarize, what is very important in critical care management of subarachnoid hemorrhage is that the initial patient care is directed at reversing or stabilizing life-threatening conditions, particularly for comatose patients. The important steps are ensure a secured airway, normalize cardiovascular function, treat seizures. Okay, these are the indications for endotracheal intubation. GCS score of less than 8, elevated ICP, poor oxygenation, hypoventilation, hemodynamic instability, and requirements for heavy sedation. Grading of the severity of subarachnoid hemorrhage is actually very important because it would dictate what approach there is safe for the patient. Okay, so there are several grading systems. Hunt and Hess, World Federation Neurological Surgeons, classification, and the Fisher grade. These are the more common ones, which influence the surgeon's decision of what approach to do. So the most important goal in subarachnoid hemorrhage management is to prevent rebleeding by early repair of the unsecured aneurysm, surgical or endovascular coiling, to implement measures to reduce the risk of neurologic and systemic complications, vasospasm, and delayed cerebral ischemia. Blood pressure control is very important. Maintenance of euvolemia, okay. Treatment using nimodipine, bed rest, analgesia, venous thromboembolism prophylaxis, and discontinuation of antithrombotics. So conditions which may relate to poor outcome are hypoxemia, hyperglycemia, fever, and cardiovascular instability. Okay. So for blood pressure, these are our goals. Maintain systolic blood pressure less than 160 or MAP less than 110. Okay, it's reasonable to use pre-morbid baseline blood pressure of the patient, and hypotension must be avoided. So these are the recommended drugs. Okay, And we always have to maintain CPP at the threshold of around 70 to prevent the risk of infarction. Okay, so what else is here? So as you can see, them all up. And what we call this? What about triple H therapy? It no longer applies. Okay, MAP is targeted, as I've mentioned earlier, and we need to achieve euvolemia rather than hypervolemia. Okay, because remember, there's also a cardiac manifestation of a ruptured aneurysm. Okay, and the hematocrit should be just around 30s for adequate CPP and cerebral blood flow, because otherwise, what you call this, we might overhydrate our patient and do hemodilution that may compromise the cardiac status of the patient. So this is something new with